extend my warm welcome to the distinguished chief guest and guest of honor. Sir, it has been an honor to have you and your views regarding the primordial prevention and the lifestyle modification for the prevention of the non-communicable disease, and we definitely would look forward to keep this promise from IMA Prayagraj. With this, I would like to welcome all the delegates who are amongst the audiences and the faculties, the distinguished faculties which we have in the field of cardiology across India. We have renowned cardiologists, and it would be a pleasure to hear them out. I would convey my best wishes to Dr. Abhishek Sachdeva, who is the organizing secretary, and his young dynamic brigade of co-organizing secretary from Department of Cardiology, Motilal Nehru Medical College. Without any delay, I would like to invite Dr. Mohammad Shahid, who is the Associate Professor in the Department of Cardiology, to start the scientific session. Dr. Shahid, the stage is all yours.
A very warm welcome to all the doctors out there. So without any further delay, we will just start the session now. So to start the session, I would like to call upon the chairpersons, Dr. M.K. Madnani sir. He is a senior physician and director of Madnani Hospital, Prayagraj, and he is the past president of IMA as well. Next on the stage, I would like to call Dr. G.S. Sinha sir. He is the senior physician of Rajan, and he is again the past president of IMA. And Dr. Nikesh Mishra, he is assistant professor in Department of Cardiology, Sutherland Medical College.
Good afternoon, everybody. I welcome you all to this annual conference of IMA. College of General Practitioner. It's my privilege to welcome our first speaker, Dr. Rajan Modi. He is a senior consultant, interventional cardiology and structural heart disease, Sarvodaya Hospital, Faridabad. Now I invite Dr. Modi for delivering his lecture.
Medical Association for the great opportunity to speak in front of a great audience. All the dignitaries present and all my fellow speakers. First of all, great auditorium, guys. It was amazing to see such a nice auditorium. And so before we started, I think we got two great talks by our two dignitaries, and it was a very good food for thought, where we spoke about prevention, we spoke about how we can do without non-medical treatment, which was really interesting, and it's a thing we should think about. So, you know, when we were kids, we were always told, all of us were told by our parents, score higher, get higher marks. As we grow older, I realized, especially as a doctor, hypertension, score low. Go low as you can. So I think one of the biggest problems in cardiovascular disease, hypertension, is when you can keep your blood pressures as low as possible. So do not score high, score low. It's an irony, but yes it is. So it's a global public health crisis, we all know this. 55% of all cardiovascular diseases, which means strokes, MIs, renal issues, peripheral vascular diseases, are all due to hypertension. It is the main cause of death, and 45% of patients die because of your heart disease, 51 almost died due to stroke. It's one of the most important non-communicable diseases in India. Most of us are underdiagnosed and undertreated. Most of us do not know we are hypertensive until unless we reach to a doctor. Most of us always think of, it's a headache. I often on and off keeps getting headache, or it's migraine. But these are not. If any time you have headaches, please get your blood pressure checked. It is very, very, very important. 90% of the people who come to see us in our clinics as physicians have hypertension rather than headaches and migraines. In the last 6 decades, it has gone up tremendously. It's about 12-fold in the urban population, 7-fold in the rural population, 12-fold more in the urban populations because of stress, because of work stress, family stress, because of social media pressure stress nowadays. So that's why young people are getting more hypertensive, because everybody wants to be the forefront, everybody wants to be liked, all the likes, all the comments, all the hearts which you get on your social media is one of the causes you get hypertension. So in 2002, JNC7 was the one which started hypertension treatment. They actually defined systolic and diastolic blood pressures, and they gave a classification to us which said, what is normal blood pressure, which is less than 120/80, pre-hypertensive 120 to 139 and 80 to 89, stage 1 and stage 2 hypertensives as mentioned. Now this JNC7 actually told us, these are the readings of hypertension you need to be looking at. Now JNC7 after 10 years was followed by JNC8. Now the problem with JNC7 was, when do we start antihypertensive treatment? Will it improve health outcomes? It didn't answer. So JNC8 had to answer it. It specified with antihypertensive pharmacological therapy will lead to actual improvement in health outcomes. And do hypertensive drugs and drug classes differ in regard to specific health outcomes? Now what JNC8 helped us to do was, it said, in order to lower systolic blood pressure of 150 or a diastolic of 90 for a general population, you need initiation of drugs. So if you have a blood pressure which is more than 150 and 90, you need to start drugs. Your target should be at least to start pharmacological treatment should be more than 140 and more than 90 in systolic and diastolic blood pressure. In patients with age of 18 years old with CKD, we need to start pharmacological treatment to lower blood pressure at 140 and 90, and our treatment to goal is keeping the blood pressure less than 140 and 90. Also in diabetic population or older, again 140, less than 140, less than 90 was again the target blood pressure. They said initial treatment for non-blacks, which include diabetics, should be thiazides. Also, thiazide diuretics and calcium channel blockers should be used specifically in patients with diabetes, and AC inhibitors played a huge role according to JNC8. So these were the few things which JNC8 actually specified to us, and this we're talking about 2013-2014. Next came the biggest trial which was made, the SPRINT trial. Now, what this SPRINT trial did was, it helped us divide if we actually needed to go below 140 or 140 was okay. So it divided about 9,000 patients at a 3-year follow-up into a standard treatment goal of 140 or an intensive treatment goal of less than 120. Now, why was this important? As we went lower, which meant intensive treatment goal. Now, intensive treatment goal, we're talking about lifestyle modification plus pharmacological therapy. We had 25% less CV deaths, 27% less all-cause mortality. So CV deaths include stroke, kidney problems, MIs. So 25% deaths came down. So intensive treatment was better. Now, people started asking, intensive treatment, what about side effects? This was what the side effects showed. There was not even a single statistically proven side effect when we did intensive treatment or standard treatment. So this meant intensive treatment with a blood pressure of less than 120 is actually needed for you to prevent further complications in CV deaths and mortality. We start talking about high-risk patients. In whom do we need that intensive treatment more particularly? Which are that group of people? Those are the group of patients which are known as high-risk hypertensives. Who are high-risk hypertensives? All patients with stage 1 and 2 hypertension with 2 or more risk factors. With having symptomatic cardiovascular disease, a CKD, diabetes, or any end organs damage which includes peripheral arterial disease. So males go into the risk of high-risk category. More than 55, females more than 65. Dyslipidemia, diabetes, blood glucose levels are higher, obesity, renal dysfunction, retinopathy, cerebral vascular disease, symptomatic organ damage, or any history of any family history of coronary artery disease. So these were high-risk patients. These needed to have intensive BP lowering. Why was this important? Now, when we start looking at risk factors, if you look at this table, as the risk factors go up and as the blood pressure goes up, the chances of you developing a CV risk over 10 years becomes very high. So if you have no risk factors and your blood pressure is a 180, it's very high. If you have one risk factors, again. So as the blood pressure is going up and as the risk factors went up, the risk of a cardiovascular disease were high, so we needed intensive blood pressure to come down drastically with lifestyle and pharmacological treatment. what happens once we bring it down for every 20 mm. So if you have a blood pressure of 140, you bring it down to 120, and you bring your diastolic from say 90 to 80, your CV risk reduces by about 40 to 45%. And as it starts going up, your CVD risk increases. So if you had a blood pressure of 130, it's gone up to 150, your CV risk has doubled. It's become from 2 to 4%, which is very, very bad. The problem becomes is hypertension control is still a problem. Why is it a problem? In almost 2 in 3 patients of hypertensive patients never achieve a target of less than 140/90. We are still not able to bring them there. 1 in 2 patients of stage 2 hypertensive also do not receive blood pressure codes. Reasons: we are bad with monotherapy. We start one drug, we think one drug is going to control blood pressure. That doesn't happen. We have a fear, physicians have a fear that it's going to lead to more adverse effects. Patients start telling us, so we are taking too many medications, side effects हो रहे होंगे, please come कर दीजिए. No, we should not. Higher costs. Patients' compliance. Most of the times, most patients do not take the amount of medications that are being advised to them. So originally, the concept after JMC, after Spirit trial was, you know what, let's start with monotherapy. We titrate it, go to a second agent. We go further up, increase the dose of the second agent. If that doesn't work, go to the third agent, increase the dose of the third agent. This was known as a stepped care approach for hypertension. Now, once we start with monotherapy, BP responses in case of monotherapy is just about 30 to 60% with different drugs. So if you're taking thiazides, the response is only seen in 50% patients. If you put patients on beta blockers or AC inhibitors, calcium channel blockers, all of them, the responders for a blood pressure on a single medication is maximum 50%. So 50% of your patients will not respond to monotherapy. So if your patient comes to you and put them on say on amlodipine or a calcium channel blocker, 50% will respond, 50% might not respond. So monotherapy is not the answer. So there was a shift, why should we stop stepped care approach? Because one, it was very difficult to control the elevated blood pressure, and blood pressure just doesn't work on one mechanism, it works with many pathways. So why not target all pathways? Let the CCBs target their pathway, let the AC inhibitors target their pathway, let the thiazide diuretics target their pathway. So if we can control all 3 pathways, we'll be able to bring your blood pressures furthermore. And we do not know in which patient that pathway is problematic and which pathway is working and which is not working. So there's a various combination therapies which were present, where we can use any of this combination. And that's why we start with the approach of a combination therapy. Now, as we increase combination therapy was found to be 5 times more effective. So if you put the patient on 2 hypertensive agents, it was 5 times more effective than putting the patient on a monotherapy. It improved tolerability, it improved adherence to therapy, and it was also associated with long-term blood pressure outcomes. When we look at this chart, look at this. These are the patients who have achieved primary endpoint. Endpoint of less than 140/90. Initial combination therapy, 75% almost achieved target blood pressure which we wanted. But originally with the monotherapy, only 50% achieved. Patients who had achieved less than 140 blood pressure were almost 61% patients, whereas in monotherapy only 43% achieved it. So it was very well known after these studies that monotherapy is not going to work. We need a dual therapy to be done for these patients. So in combination therapy, there were few trials which were done which showed combination therapy, sequential monotherapy, and stepped approach. It all showed that initial combination therapy, rather than a single therapy or a sequential therapy or a stepped care approach where we're increasing dosage and then adding another medication, initial combination therapy was very more effective with a 62% patients achieving your target blood pressure. And this, what it did was, it was able to reduce your risk by 34%. So if you're starting the patient on amlodipine or AC inhibitors alone, why not put a combination of AC inhibitors and CCPs? That will help you reduce your blood pressure by almost 34% and reduce the risk of any CV events. So the efficacy increases, the safety increases, and long-term outcomes for these patients are very, very nice if you're giving them a combination therapy. The average agents used in most of these patients who had blood pressure was almost 3 agents, 3.2% agents. So if you look at all these studies which were done, it showed that the number of antihypertensive agents which were used to bring down blood pressure were almost 3 and above. So we needed 3 agents. It was not now a topic of monotherapy. It was topic of how to bring down the blood pressures by combination therapy, and that to a combination therapy which requires 3 or more agents. So this combination therapy said, any 5 classes of drugs, thiazide, beta blockers, ACE inhibitors, ARBs, CCBs in fixed dose were studied, and it was shown that 20% lesser dose was required for them if you use them in combination therapy. So if you are using amlodipine of 10 milligrams, you could come down to 5 or 2.5. If you're using a ACE inhibitor of 40, you could come down to 20. If you're using diuretics of 12.5 or 25 at hydrochlorothiazide, you would come down to 6.25. So we could reduce the drug dosage by adding another drug and reduce the blood pressure drastically, and thus reduce the CV events. When used in combination therapy, systolic blood pressure actually reduced by 20%, diastolic came down by 20%, and stroke risk reduced by 2/3. Heart disease reduced by half. So these are wonderful statistics which show that don't use monotherapy. Do not start the patient if he comes to you with a single drug. Start the patient on dual drugs or triple drug combinations according to your blood pressures, and you will be able to give them the benefit of why we are starting them on antihypertensives. So effectiveness, as we said, the chances of frequent titration, he comes to you, you increase the dose, you decrease the dose, becomes lower. The blood pressure improves at the start of the treatment, so you don't have to wait for 6 weeks, 8 weeks, 9 weeks, 10 weeks for the blood pressure to start improving. It gets improved itself at that very moment. The best combination which was shown in a lot of trials was ARBs, the CCB with the thiazide diuretics, because it can take control of 3 different mechanisms and thus reduces blood pressure drastically. And the best part was we could bring down diuretics to about 6.25 only, and even that led to that the incidence of hypokalemia and hyperuricemia was actually brought down. So if you use ACE inhibitors with a CCB and a thiazide diuretic, we could bring down all those adverse effects, we could bring down the dosages, and we could control blood pressure much easier and better way. So it was said that reduction of blood pressure with all 3 agents, actually 96% patients showed that there was an effective response or an excellent good response with a triple drug. Now we are talking about all statistics. These are talking about 5,000, 10,000 patients. So these were the initial things which came in hypertension from 2003 when 2004 when JNC7 came, down all the way to 2017, 2018. Recently in 2023 is what we have got the recent updates, which are the European Society updates for hypertension. Now what it says, which is different from what previously thought, I'm just going to specify those. It says that previously we were taught that let's check, to avoid white coat hypertension, let's check blood pressures at home. What it says now, which is from 2023, is that we need to have multiple office blood pressure measurements and blood pressure tracking either at home or ambulatory blood pressure. So you're taking blood pressures in the clinic, you're taking blood pressures at home, you're taking ambulatory blood pressure monitoring, and depending on that, you define if the patient requires hypertensive medications or not. So it is just not blood pressure at home, it is just not ambulatory blood pressure, it is just not blood pressure in your clinic or in the hospital. It is a combination of all 3. So please ask your patient to monitor their blood pressure at least once a day, check their blood pressure, bring them down, write them down, bring it to you so that you know what's their hypertensive status. Because most of the times these blood pressures fluctuate when they are in your clinic or when they are out. It also changed the score. Initially there was a PCE score which the ECCAHA, American College of Cardiology, used to evaluate what is the cardiovascular risk. It has changed the score to a score 2 tool. The score 2 tool is available online, we can anyways calculate. What the score 2 tool does is, does not help you take decisions of hypertension, what drug to give, but it tells you what is the cardiovascular risk. Is the patient at risk for developing a stroke? Is the patient at risk at developing a heart disease? Is the patient developing any other cardiovascular event in the future? The higher the score, the more is the risk. So there were a lot of similarities between the 2017-2023 European Society guidelines. As we said, office blood pressure management plus the ambulatory blood pressure plus home blood pressure. In the pharmacological recommendation, what it said was that the initial therapeutic choice like ACE inhibitors, ARBs, thiazide like diuretics or calcium channel blockers should be used, and it should be a combination of these 3 rather than having monotherapy. A single pill combination therapy is the first line strategy. So do not start with monotherapy, at least try with 2 drugs, if not 3 drugs, because 3 is what an average antihypertensive takes. We all know these readings. The basic change which has happened from 2017 and to 2023 is, yes, between the ACC and European Society, there were always difference in what we define as stage 1, stage 2, or grade 1, grade 2, grade 3. Normal blood pressures are still being maintained by both societies as less than 120/80. So please remember, less than 120/80. We're not talking about 130s, we're not talking about 140s. A normal blood pressure means less than 120/80, or an optimal blood pressure. Target blood pressures, yes, if it's less than 130/80, we are happy, but you can still bring it down. If the patient is having no side effects, if the patient is comfortable, if the patient has good dose adherence, why not bring them down to a normal blood pressure of 120/80? There's been no studies which have shown that bringing down blood pressures is going to cause a problem. So if a patient comes to you, irrespective of age, and we talk about more than 80 years also, irrespective of age, if the patient comes to you and has a blood pressure of 140/90, I would rather want to bring them down to a blood pressure of less than 120/80 rather than keep him at 130/80. What the big difference between these two guidelines in the pharmacological therapy? What the European Society said now was that beta blockers should be included as a first line therapy for hypertension, which the American Society did not ever say. The American Society only said for beta blockers if you have a cardiovascular disease, if you have any angina, if you have any peripheral. But what ESC said was beta blockers need to be included in the first line therapy. Now this is a big change because beta blockers initially was only if you have established cardiovascular disease, atrial fibrillation or any angina. So the recommendations for drug therapy by the 2023 guidelines said lifestyle modifications need to be done to prevent, treat and delay the onset of blood pressure. Now here I like to talk about lifestyle modification. There's a lot of patients who come to us saying, sir, salt causes me blood pressure, I have stopped salt. No, salt does not cause you blood pressure, the extra salt causes you blood pressure. Please do not stop using salt in your diet. Second query, most of the times the patients come to us with, I started rock salt, I started Sendha Namak, it has low sodium, they are now low sodium. Salts in the market, I've started those. Please do not use them. They all have low sodium content. Patients, specifically octogenarians who are slightly on the higher elderly patients, any hyponatremia, any low sodium can actually cause you more harm, cause you falls, cause you fractures, cause you head injuries rather than salt being on the high side. So our sodium should not be 130 and lab report should not be 125, should not be 124, it should be 135 or 140. So stopping salt will never help your hypertension after a particular age. You need a particular amount of salt in your diet. So whatever salt is being used in your diet for cooking for the entire family, please use that. Do not stop salt. It's not going to help your blood pressure. So more than 80 years, as we said, if older patients more than 80 years, they have said that they recommend drug therapy if the systolic blood pressure is more than 160. Whereas ECCHA said that they do not want this distinction. Now this is a very grey area where it is very dependent on what a physician thinks. For a lot of people, a systolic blood pressure of 160 for 80-year-old is still not good. Bring them down to 130. See, all these guidelines have been made not for you to practice them as written by them, but they help you in making a decision. So if you have a patient who has blood pressure higher, it will help you make a decision what drug to use. If you have a patient higher and you don't know how to change the drug, they will help you make a decision on what other drug can be used. There should be a combination of drug or monotherapy. But do not strictly go by these guidelines because all patients are different. You need to make a prescription for a patient very subjective to the patient. So do not always believe these guidelines. Pharmacotherapy, as we said, is the European Society has added beta blockers as the first line therapy. That is very, very important. They have said if a hypertension treatment needs to be done, please start beta blockers. There is nothing wrong in that. Single pill, we already spoke. Use 2 combination drugs. Do not use monotherapy. Use 2 drugs or 3 drugs. It is good. It will bring down your blood pressures. It will bring down the compliance for the patient. Patient will take 1 pill. He will be very happy instead of taking 3 pills. From the moment you start blood pressure treatment, patient will be able to control his blood pressures. So it's very, very nice. Plus, your doses of your blood pressure medications will come down. They have also added renal denervation therapy as another method to control blood pressures, and that is specific only in patients who have resistant hypertension. So in patients who have resistant hypertension means patient is already on 3 drugs, which includes one diuretic. If the patient's blood pressure can still not be controlled by them, then renal denervation therapy is a good option. Now, this is a basic selection criteria for renal denervation. Any patient who has a primary hypertension, has resistant hypertension more than 140/90, is adherent or non-adherent to medications, means if he's already on medication, still not blood pressures are not getting controlled, has elevated sympathetic activity, has an accessible accessory renal artery, has an eGFR more than 40, then these are suitable for renal denervation. Please remember, it is only these points which are suitable for denervation. Kindly, we should not advise renal denervation to each and every individual. Start them on lifestyle changes first, put them on combination medical therapy. If they still do not respond, then yes, renal denervation is a good option for such patients. Let's come to blood pressure in more than 80s octogenarians. You know, there was a study in 2013, there was another study in 2016, which actually started checking, what is the incidence of fall? People always say, blood pressures became low, I fell down, I had a fracture. So they started looking at all patients who had fractures because of antihypertensives. And they started looking at it and they found, there was no increase in fractures if you brought down systolic blood pressure in the 135. That was not the cause of fractures for those patients. So they actually divided them into 10 groups from 125 to 185, and they found that the lowest mortality was actually in the 135 to 145 systolic group, which means if you even bring down the blood pressures to 135, between 135 and 145, patients is going to have a good CV mortality, decrease in CV mortality, plus there will be no side effects. So do not look at those 160 with the SCSN. There are a lot of trials which have said that in such patients also you can decrease the blood pressure even at 80 years, 85 years to 135. It is nothing is wrong. So the take-home message I would want to say is hypertension is a global risk. Every 20 mm increases your CV risk by 40 to 45%. 50% of our patients do not achieve blood pressure goals. 140 is not the blood pressure we want to keep in our patients. 130 and less or 120 is much better than 130. Instead of the traditional step approach, we could actually start a combination approach which can help in bringing down your blood pressures drastically. Blood pressure monitoring in the office, at home and ambulatory, all three are needed for us to take care of blood pressure pharmacological treatment initiation. Combination therapy is the first approach which should be taken. It is 5 times more effective than increasing a single dose and then going on to your second dose. At least 3 agents are required in one patients, at least with 1 or more risk factors. So do not feel bad that if you're starting the patient on 3 drugs. And most of these 3 drugs help the systolic blood pressure come down by at least 20 mm. Low dose telmisartan plus amlodipine plus thiazide is a unique combination which has been proven in various studies as the best combination to bring down your blood pressures. And in patients in whom this monotherapy with diuretics is not applied, then actually switch to a triple combination therapy directly rather than increasing it. Beta blockers should be added according to recent guidelines. They are very helpful and they need to be done. And renal denervation still remains as an alternative treatment. Thank you so much.
Thank you, Dr. Modi, for a lucid and a very informative talk. I think you were talking about essential hypertension rather than anything else. And as it says essential, so it literally says, जैसे कि आपने initially बोला 90%, so maybe जितने हम लोग बैठे हैं 90% of all of us are having hypertension. अगर नहीं है तो हो जाओगे. Hypertension essential, I mean, am I right about it or not?
So I would say, I think if we look at the crowd, even including me, I would say most of us are slightly on the overweight side. The first thing in blood pressures people start forgetting is blood pressure treatment is not medications. Blood pressure first treatment is lifestyle changes, which includes not restricted stopping sodium. Restricted sodium, yes, but bringing down your weight. Weight is the most important factor in most cardiovascular disease. We all are overweight if you start with the drug. So bring down your weight.
I'm talking about the nomenclature.
Yes, it is essential.
Essential means कि सबको होना चाहिए.
Exactly.
So I think it's a thought to be सोचने की बात है कि ये नाम सही है कि नहीं है. मतलब essential mean होना ही चाहिए. So अगर ऐसा है तो it's a sort of elephant in the room.
It's going to
सबको है and
it is underdiagnosed because most of us are not. When was the last time you all checked our
Hello.
blood pressure? I don't remember. So we need to check our blood pressure. Essential. As age grows up, we all are going to develop hypertension at some point of time. The only question remains is how high we let it go. How many risk factors get involved in that hypertension, and how free we are to let the CV mortality go up because of hypertension.
Number two, patients with comorbidities. They have a different sort of, not 120 by 80. Say for renal patients, a little higher, I suppose. For cardiac patients, it may be a little lower. So with the comorbidities, you have a different goal. Number three, for all the hypertensions, would you tell us कि आज हमने इसको detect किया, हमने दवा दिया, उसके बाद how early I should call him और कितनी जल्दी मैं उसको कम कर दूँ? Because in diabetics हम तो बोलते हैं कि 3 महीने तक दवा अगर नहीं होगी तो I'll accelerate or add some drug. What is your experience or advice in these patients in hypertension?
So we generally call our patients back in about 10 to 15 days. Most of our patients, our target blood pressure remains irrespective of CKD, irrespective of diabetes, is 130/80 as a whole value. If the patient is not a CKD, we would rather want to bring them down to 120/80 and below. That's fine. Start them on combination therapy, call them after 10 to 15 days. Why? Because we want to bring down blood pressures as quickly as possible. If a patient blood pressure has a 155, I want to bring it down to less than 130. So call them after 10 days. Let us repeat those blood pressures. Let us see how they are. If they are still on the high side, then we can slightly increase the dose and start them on combination therapy.
Agreed. So this is what I wanted to point out for the benefit of all the audience. The house is open for question and answers.
I want to know that we always talk about the systolic BP more. Like all your slides were showing this by 80, this by 80, 120 by 80, 130 by 80. Some of the patients feel vertigo, maybe false vertigo when the diastolic BP goes down. And maybe 40, maybe 30, 25, even 55, some people complain of vertigo. At that time, what we do not know at what is the target to keep the systolic, because we are more concerned of the low diastolic BP. Because what we know as a physician that low diastolic BP is also very harmful. So we do not know that if a patient is having 170 by 45. So, like we know calcium channel blocker will lower down altogether the diastolic BP. So we do not have to prefer calcium channel blocker. But we do not know which things and how much to lower down 170 BP according to the age and according to the symptoms. This is the totally opposite aspect of what you did.
If a patient comes to me with a 170/45 blood pressure, I will start thinking of other reasons, any regurgitation which is there. So let us evaluate the patient to find a reason for that low diastolic blood pressure. If that is such a low diastolic blood pressure, then there might be something on an echocardiography with any valve regurgitation which is causing that. Aortic regurgitation may be bringing down with having a wide blood pressure which is there. If still it is not there, there has to be a specific etiology for diastolic coming so low and systolic going high. It is not possible that you get patients which have 170 blood pressure and a 40 diastolic without a cardiovascular etiology or a structural problem in the heart. So we should evaluate them, find out the reason why they have such low blood pressure. If we actually correct the reason, you will find that their blood pressures are actually 170, 110 or 170, 100. So if a diastolic is very low, try and evaluate the patient for the reason for a diastolic low blood pressure.
Sometimes we find that the only changes in heart are due to long-standing hypertension, because these patients are totally non-compliant and they are accustomed to 170 systolic. and that is why there is hypertrophy of the heart, and rest other things we do not find except in elderly, where we find mild trivial TRMR like things. So we are confused how much to lower down the systolic.
Blood pressures of 170 are still bad. We need to bring them down. You need to bring 170 down. You need to at least bring them down to 140, 150. You cannot keep a patient at 170.
Even if the diastolic is 45,
the diastolic will get better, no worries. Their patients will not have a typo. Diastolics will get better. Diastolic will not fall further down.
Fantastic talk. How are you?
Hi, sir.
So basically, your concern is that if we lower the BP down, so the 40 may come down. So 40 doesn't come down. So that is because of severe atherosclerotic disease, and there is vasodilation, so it is there. So once you control the systolic, so you get the systolic down to 140, 130, 150, but the diastolic will remain at 45.
According to the agents we are using, because if we use calcium channel blocker, that is definitely going.
Sorry for interruption, Dr. Omar, Dr. Poonam. The sponsors are saying they are running short of time, so please cut it short.
Okay, thank you.
Somebody SS, Dr. Nidhi to be precise, she says कि essential ना नाम रखे, इसको idiopathic hypertension का है.
Age-related hypertension. Thank you so much.
Take the session further. Thank you, Dr. Rajan Modi sir, for the very brief and very crisp presentation on hypertension. Thank you so much.
And felicitate our chairpersons and the speaker for a very good presentation and discussion.